morning, everybody.
You can
You're
move
out
of your way.
Good morning. The room's a little bit awkward, but it's a lovely room and it's not smelly. So we're pleased that that's the case. I'm Jonathan Weiner, one of your hosts. I'm a longtime professor at the Public Health School here at the Bloomberg School of Public Health in Boston. We're in actually a building that's owned by Lake Mason. However, Johns Hopkins University rents some of the space for the business school. Public health school digs aren't quite as nice as the business school. So we're really ecstatic that you're all here. And that one of the first sunny days in 2 weeks, so at least that's happened. This is a very exciting event, an unusual event. It's purposely limited in size, an invited event with many senior people. Almost everybody in the room is very well, everybody in the room has a lot of ideas, and almost everybody in the room has the power to put those ideas in place, so that's very exciting. We have academics who have a lot of ideas and not a lot of power. We have people that run health systems and payers. We have different types of IT companies, EMR companies. We have people from government, state, and local, and many others in between. One thing we all have in common is the interest in the health of our communities, our patients, and populations. And we all have been drinking the Kool-Aid. We understand that health IT, electronic medical records, and health, the digital convergence really has great potential. And it really will happen one day, hopefully in our lifetime, but certainly in our children and thereafter lifetime. And this is the opportunity to really have an impact. Thank you so much for coming. The focus, as you see there, is really on trying to help set the research and development agenda. That's what research and development is. We'll talk about today. In the 20 minutes I have left, to tell you a little bit about the conference, why we're here. Because I think, not that this is a really senior group of people, we're flexible, but you see we provided a lot of structure. The reason we provided the structure is we then will have full flexibility while we're here. Things will change, will be dynamic. Anything that we've laid out can be changed. We have, by the way, 12 great moderators, 2 for each group, very senior people, and also a student for each group. That will allow some structure for what can be a very wide-ranging discussion. But our aim is pretty simple, to help set the national R&D priority for the newly emerging field of population health informatics. And you might say, what is population health informatics? So actually, one of our activities is to continue. I won't say to start, because we've already started, but to continue to agree to disagree, or at least have a working definition of what we think. And it is somewhat contentious among some camps, right? Some of you may have attended the American Medical Informatics Association. We had a session last conference actually debating should or shouldn't we call it public health informatics or population health informatics. Should we call it IT? Should we call it informatics? And as long as we understand, what I tell my students is understand the different labels, understand the different concepts, and then move on. So hopefully we can, even though there might be some disagreement, at least talk about what it is and why it matters. But why we're here, thank you for some of our representatives here from the ONC and from CMS and President Obama, with the HITECH Act. Most of us in these so-called health policy experts weren't so sure that the ACA was going to happen, but in the meantime, HITECH did happen, and this is the result, the latest from the National Center for Health Statistics. Chesley, who heads that up, thank you for all the good statistics from the CDC's unit. But it's always astounding. 78% of all the doctors, this was last year, have an EMR on their desk. What they're doing with it, that's, everybody in the room, of course, spends a lot of effort on that. But the fact that they have it on their desk is necessary but not sufficient, as they say. But it certainly is the necessary piece, and that's what's motivating us here today. And it's not just the EMR, and what has started us at the Center for Population Health at Johns Hopkins, we call CPHIT, is the understanding it's challenging enough, and many of you face those challenges. We have 3 or 4 CMIOs in the room. We have most of the major EMR vendors are in the room. You ladies and guys understand the challenges better than I, getting the doctors to do what they need to do. But multiply that factorial when you think about the community. And having spent 40 years, 35 years, whatever it was, if you include my doctoral career in East Baltimore, if you've ever visited East Baltimore, you know the challenges. If you ever watched The Wire, you know the challenges. It's a pretty big factorial, and one understands how do you translate all of that into really what matters, and that is the health for the people we care about. But that's the starting point. When you say about population health informatics, and at Hopkins, we're a great place. We need more medical informaticists, clinical informaticists. We're not quite as big a leader in that as we are in some of the other domains. But we must remember that in this space, not only do we need the information science, and you realize even that those terms are loaded too. Clinical informatics, my computer scientist colleagues say, what's that? You know, and information science, which formerly known as library science, like computer science or informatics colleagues sometimes say, what's that? So again, all the labels, but there are many professionals in many different domains. And although we may only have 3, 4, 5 informaticists at Johns Hopkins, we probably at last count have about 2,000 people that do nothing but work with data and information. So, you know, let's not get caught up in the labels, but understanding the importance of information and the respect and importance of the information sciences. But at its heart, I don't know how to code in HTML, but I do use the computer a lot. And at last count, I have staff working on hundreds of millions of records every day, and I don't code. But what is important is we do know population sciences, we do know epidemiology, we do know health services. So that's the pink there, which Sam, I think, is the public health color, so let's pick that. And obviously, there are many doctors, nurses in the room. You can't do this without the clinical knowledge, the clinical base. And not to mention, this is just sort of the scientific part, not to mention the infrastructure of delivering healthcare. We have 4, 5, 6 integrated delivery systems in the room. That's essential. And we have the leaders. And the leaders, I have many friends, and over a beer or two, they'll say, we are the leaders, but you should see the rest of the guys. So, meaning that we have a long way to go. And where's Buzz Stewart from Geisinger, Intermountain? He always says, not Intermountain, Sutter, he always says we're the giants among the midgets, or the midgets among the giants. Meaning you all know the challenges even among the best organizations where we have to go. So we have a long way to go with the science. We are going to talk a lot about healthcare and medical care and insurance and ACOs today, but just to get it out there, as a professor of public health, and probably everyone in the room to varying degrees understand it's not just about medical care. In fact, it's not about medical care at all. This is Minnesota, based on the great work of David Kinding and others in Wisconsin. Various analyses, one can quibble here or there, but healthy behavior, socioeconomic, physical environment really eclipses the medical care process in terms of well-being of the population. Now, obviously, you've got to start somewhere, but I think just to remind everybody of that. Yes, please, there's plenty of seats up front. By the way, these slides and all other slides we'll make available on our protected web page, and so everything and we're glad to send copies if anyone would like them. So, in your packet, I forgot to mention, in your packet we have a few things. We have, first of all, the bios of our 3 great keynoters. We have the proceedings, which have the schedule. We also have these definitions, which I call working definitions, which we'd like you to mark up, because when we put them together, we had a planning group made up of colleagues at Hopkins and 12 moderators, some on the outside, from different types of disciplines. And there wasn't full consensus, but enough to let's get going and put this out. We also, you'll see a bunch of footnotes. So we encourage you, we've started actually, we thought we were going to actually have a discourse on this. We said, let's move on. Let's start with this. If anyone has strong problems with this, let us know. And you will see on page 4 of your handout, page 4 of this proceedings here, actually has these definitions with several footnotes. So if you strongly agree with some of the footnotes, let us know. If you have other footnotes you'd like to add, let us know. Otherwise, we will sort of move on. The population health comprises organized activities for assessing and improving the health and well-being of defined populations. We'll come back to that in a moment. Population Health Informatics. By the way, we started with PHI, and someone said, wait a minute, PHI is something else. So we went with PHIT, which some people don't like because IT is not informatics, it's not information, but nonetheless. Population Health Informatics is the systematic application of IT, there it is, and electronic information to the improvement of the health and well-being of a defined community or of their target population, which is a controversy. We'll come back to that as needed. And the controversy, that's this. Public health, we have local, state, federal health officers and folks here. God bless you. And we'll see in a moment, though, some of the challenges of dealing with an entire community. This isn't England or the UK. Even we have a visiting professor from Scotland, and even the UK is not the UK anymore. But the concept of the NHS or somebody worrying about the entire community, I don't know very many places that quite do that. This is the controversy. If you're working for an integrated delivery system or Aetna or United, both Care First, all of whom are represented here, and I'm really gratified how much they're moving toward population health. It's only a subpopulation. On the other hand, if you add all the circles together and you coordinate, well, maybe we're there. So you might say, you know, you're a professor of public health, Jonathan, what are you doing talking with health systems? What are you calling this, you know, population health, not public health? This is why. These are the views from my window. This is the Sheikh Zayed and the Charlotte Bloomberg Tower. That's the Sheikh of Abu Dhabi, and you've all heard of Mayor Bloomberg. It's very ecumenical, by the way, you know, a Muslim and a Jewish tower side by side in a Quaker hospital. But anyways, Johns Hopkins was Quaker. This is the other side of my building. This is a professional photograph. This I snapped with my iPhone yesterday, the day before. This is Josh, who used to run this East Baltimore Center, and as I understand, actually got a start with our public health school. 1950, 1934, I'm not sure, but it's been around for a while. This was recently built at $1.2 billion, the most expensive hospital in America. You know, we understand the resource constraints, 2 trillion, 2.2 trillion versus roughly 0.075 trillion is my estimate. About 3% of healthcare dollars go to public health. I tried hard to come up with the IT informatics budget, and some people in the room might help me with the overall, whether or not it's 15 or 40 billion a year in overall medical care IT. My estimate is about 0.5 billion. So I'm a practical guy. If we're going to impact the health of the public, I like those numbers better than the other numbers. But we can continue that discussion. Some of you have seen, it's a little hard to see in this room, but when we talk about HIT, we talk about, and I'm having a hard time, I don't know where to point, because there's 2 of them here. But we talk about really, I'm sorry, I'll just point at one at a time. You know, the doctor-patient sort of in the center there. Around him or her on this side would be the family and community. On the clinical side, it's the practice team, you know, PCMH, whatever. And now increasingly, we have several ACO directors here, several integrated delivery systems. We're not thinking about the doctor. We're not thinking just about the team. We're thinking about the entire integrated delivery system. IDS, ACO. I'm a big fan of ACOs. That's on the way to where we're trying to go. Most people appreciate that, you know, that is, we'll talk about ACOs later. But the main point I wanted to make is that when we talk about population health, we're certainly not talking about just the doctor and patient or nurse and patient. We're talking about all of this, family, social networks, communities. We're talking about teams, and we're talking about health systems. And what I've attempted to do, and this is the URL, will give you an article that I wrote up on this. It's not just the EMR, EHR, it's not just the PHR, it's not just the mHealth, it's not just the public health records or the claims data. And by the way, you know, what's the most widely available population health data in America? Is it the EMR? No, it's not the EMR. It's the administrative data in hospitals and in claims systems. And so, of course, those systems don't get much respect because they've been around for a while. They're not so great, but for the foreseeable future. So whatever we do must include that, and it must include human resources. And as we know from the Kindig slide, we're not doing population health if we don't get all of these other sources. Let me take a deep breath because we need our energy. There's a lot here. Think big, you know, act small. So, but I think the vision is communities, it's family, it's health systems, and it's bringing together all the data sources. And we will, in the remainder of today, talk about not only this a bit more, because it's hard to do research and development if you're not understanding what it is you're doing research and development on, but then trying to identify, chip away, as I like to say. Michelangelo didn't start with a beautiful sculpture. He started with a block of marble or whatever. And so I think we've got a block of marble, or some of the pieces are clear, but we hopefully, as a national community from all over the country, can begin to chip away at it a bit. So this also is one of my favorite slides on the ACO. Premier, some of you know, was one of the first organizations to talk about ACOs, and then Brookings took up the mantle. Brookings in Dartmouth with RWJ money. It's a little more complicated now, but not much. But at the core of one of the early ACO schemas, can you read this? Population Health IT and Data Management. So I get a big kick. I didn't develop this slide. This is the hospital, the premier buying circus, which started out getting deals on hospital supplies, right? And then it worked its way up to obviously various types of integrated thinking. So I would posit to you, many of you in the room, that's what's hot now, obviously the integrated, and we'll hear from Secretary Sharfstein in Maryland. We're on the cusp of something pretty special. All payers in the state pay hospitals the same amount, and if hospitals want to be paid, they cannot just focus on the hospital anymore. They're being paid on population health and community, and Josh and Sri will talk more about that. And so it's not just the ACOs, and the HMOs and other advanced IDSs. I think we'll see in the future it will be moving beyond that. So the symposium objectives, by the way, as far as I'm in the room yet? Well, Josh, you might go first, but we'll see. But in any event, it's always good to have a backup. You didn't have to commute quite as far as he did, but he'll be here. I'm ready. Good. But so to talk more about our definition, although in that case we've already offered you one. Secondly, although we're focusing on R&D for what? So what is our goal in achieving population health? And we have a lot of differences of opinion. Well, I don't say a lot of differences, but there's some differences of opinion. Like I said, we have public health people from different agencies. We have health plans. We have delivery systems. We have many different types of IT vendors. We have academics and others. So we have many perspectives. It's not easy. If it was easy, we would have done it already. So what are some of the challenges? And then not only the agenda, but then how can we facilitate the agenda? And although it's not your job to disseminate, I hope you talk about this when you go home, we will then develop white papers and share and web pages, et cetera. So that's really our overall mission here. If you haven't yet, during the break or if the jokes die down a bit, in each packet, the moderators did a very nice job of identifying, we call it a straw man or straw person, just getting the issues out there started. I've always learned, particularly with so many great people, there's so much to talk about. If we get in a room and say, okay, what are we going to talk about? That takes 3/4 of the time. So we're at least offering you a starting point of what you might talk about. If you don't like it, want to modify it, that's fine. So I would encourage you, in your packet, by the way, are the talking points, not just for your session, but all sessions. So we encourage you. We know that several people complained that there were too many good sessions. They didn't know which one to go to. So I don't want you hopping sessions, but we do have a good time in front of you. But we'll take a little break and I'll allow that to, Josh is here, so you had a backup. In fact, do you need 5 minutes to
I'm all set.
Okay, so talk about just in time, right? So where were we? So these are the breakout sessions, and again, all of the material is in each packet. We're actually not going to talk at all about our new center today, but I wanted to give you a 30-second plus a chance to get Farzad mic'd up. By the way, he is our speaker in case you need to give him the mic. But so the new center that we formed, we call it CPHIT, Center for Population Health IT, is somewhat unique. And what we're trying to do at Hopkins, so again, fairly simple, we call it CPHIT, but to really improve the health and well-being of our population. And starting with East Baltimore, I'm very pleased some of my colleagues here from Hopkins. They're all sitting in a row. We have one of the biggest HMOs, health plans, population-based systems in the academic medical center. We also have a big ACO activity, and maybe the second or third biggest CMMI grant, CMS grant, thank you, CMS, to turn East Baltimore into an ACO. Easier said than done, but they're working real hard to do it. So that's real exciting. And thanks to Josh Sharfstein and the folks at the Health Services Cost Review Commission, every hospital in this state, including Johns Hopkins, the tertiary care hospital of the world, now needs to focus on East Baltimore and our community and other communities. So it's very exciting. We can't do it without the types of tools that we develop at CPHIT and elsewhere. And we are linking not only the health system, but also our computer science department, our clinical informaticists. We have several of those colleagues are here today. And we are also our colleagues from the Applied Physics Laboratory. Some of you may know that a lot of the major engineering technical universities have units that work very heavily with national security and defense, and we have one of the biggest in the country, Applied Physics Laboratory, and their technology is pretty phenomenal. We could use some of it in healthcare. So our goal is to try to bring all of that, and we are collaborating both with the health system, with academics around the country, with integrated delivery systems, not just our own, but dozens, and we're pleased there are about 6 or 7 integrated delivery systems here, many of which we're collaborating with. And I have new appreciation, about half of you, a third of you are from industry, that we can't possibly have an impact without collaborating with corporations and IT companies. Some of you know that my late colleague Barbara Starfield developed a sleepy little tool that we started using in our own HMO called ACGs, and giving away disks, and 1 or 2 people used it, and 500 people knew about it, and we collaborated with various IT companies, including DST Health Solutions and other collaborators around the world, and now 100 million patients use it. It's used for them every day. So I have great appreciation for the academic model alone is not the way